Thank you, Fred. A couple of introductory comments. I think for people who don't quite understand maybe some of the subtle between the line comments that Dr. Tobis just made, Dr. Tobis and Dr. Greenbaum have been married for many, many years. And so we definitely know that Dr. Tobis knows about Dr. Greenbaum's travel schedule. And I don't know this for a fact, but my guess is that Dr. Greenbaum has more frequent flyer miles than Dr. Hirsch, knowing the travel schedules. Now, before we start, I'm looking for Dr. Atkinson. Is he in the room? There he is. Okay, way in the back. So I want to make sure he's here because before we start with this talk, I want to make sure everyone understands the numbers 43 and 13.
Oh, God, that is so bad.
Does anybody know why those numbers are so important?
You're wicked.
I'm wicked. Well, so Dr. Atkinson knows because that was the score of the University of Missouri, University of Florida football game a few weeks ago. And I want to thank you for that time in the swamp. Actually, Dr. Atkinson's colleague, Dr. Schatz, was texting me about every 20 minutes. He was not a very happy pediatric endocrinologist at the time, but that's neither here nor there now. So I don't take care of children. I take care of adults with mostly type 1 diabetes, but I see a fair amount of type 2 diabetes also. And so this is actually a very interesting topic to me as we are learning what all of these new drugs are potentially going to do for people with type 1 diabetes. And whether you have diabetes or not, all you have to do is watch TV every night to know that there's been an explosion of new medications for type 2 diabetes. So when we think about type 1 and type 2, what I want to do, first of all, is I want you to name the celebrity and the type of diabetes they have or maybe have had. Let's start one by one. Type 1 or type 2, who is this and what is the diabetes type? So it's Ron Santo type 1, and when I can't say I Googled him, when I binged him, okay? When I binged him and I looked, I thought that looks like Jerry Mathers, the beaver, who actually has type 2 diabetes, but that's Ron Santo, who grew up in Seattle. You got that right. Who's that? And what kind of diabetes? He is type 2. He does have type 2 diabetes. Notice he's not obese. We'll get back to non-obesity in a moment. Who's that? Halle Berry. What does she have? Well, that's what everybody thinks. She doesn't. Dr. Hagopian says type 2. You know what she has? She has a monogenic form of diabetes, which we call maturity onset diabetes of youth, MODY. She has neither type 1 nor type 2. Okay? It is another kind of diabetes that we have learned is passed on from generation to generation due to a gene mutation. So she has neither. Now here's the last one. This is a hard one. Who's that?
Mickey Mantle.
Mickey Mantle. What kind of diabetes did he have? See, nobody knew. So I have it on very good sources. Mickey Mantle, who of course passed away, he took insulin at the very end of his life. And we don't know for sure, but I can guess. He either had diabetes due to pancreas inflammation from alcohol, which happens. We call that pancreatic diabetes. But the more likely reason, he had a liver transplant. He was on prednisone. And my guess is he had steroid-induced diabetes. That's my guess. The point is, there's all these different types of diabetes. It's a bit more complicated than just type 1 and type 2. So, what we know in 2014, that the body mass index is a measure of the body's fat based on height and weight. How many have heard of BMI? Raise your hand. Okay, so that's not a new term. Below 25 is normal. That's where you would like to be. Above 27 is overweight. Now we're getting too heavy. Above 30 is obese. That's where you really want to be. But there's one more classification of obesity and BMI, and that is over 40. That's the person who usually sits next to me on the airplane. And that's why I don't fly as much as Dr. Greenbaum. But these are the classifications of BMI and obesity. Now, the reason why this is so important is that 30 years ago, we were taught that people with type 1 diabetes were below weight. Their BMIs were low. But actually, if we look at the T1D exchange data, this big giant registry that we have with now 27,000 patients, what you actually see here is that when you look at people who are obese or overweight based on their BMIs, and especially if you look at the adults, what you see is we're over 50% of patients who are overweight or obese. And as a matter of fact, type 1 patients now have no difference in BMIs than the general population, both in children and adults. And there are a lot of reasons for this, but this isn't the way it was. The way we look, people with type 1 diabetes has changed over the years in terms of our weight. So now wait a minute, wait 1 minute. I was taught that those with type 1 diabetes were thin and type 2 diabetes are fat. Isn't that true any longer? And the answer is not really. This is what's happened over the past 30 years. We have better therapies. Overall, the hemoglobin A1Cs have gone down when we look here in the United States at hemoglobin A1C levels. We are definitely seeing less vascular complications. That's a good thing. And we're seeing less calories lost in the urine. So if you're not losing as many calories in the urine, where are those calories going? They're going into, and some of us here, and some of us back here, and some of us everywhere, but they're going to increase weight. And we're going to get back to losing calories in the urine in just a moment. Our therapies have evolved with mealtime insulin, either with shots or pump therapy, that the weight of type 1 diabetes is no different than those for people without diabetes anymore. That's a big change. And so what would be ideal if we go to therapies are non-insulin therapies that both lower glucose and result in weight loss. And in fact, in the world of type 2 diabetes, that's exactly what has been happening. So, are there therapies for type 1 diabetes that improve glucose, lower weight, and result in lower insulin requirements? Are there therapies like that? And my first comment is there is an oldie but a very goodie that a lot of you are thinking, well, my insurance isn't going to cover this. And I would say, yes, your insurance will, because the therapy is exercise. Now, I got to tell you, and I'm talking with this now with almost every patient, this was not part of my training. This was not part of my youth in terms of what we should talk about for people, children, adolescents, or adults with type 1 diabetes. And I thoroughly believe that is absolutely wrong. And to put this into perspective, since it wasn't raining this morning, I woke up at my usual time. I woke up and walked my 6,000 steps because I have become a pure believer in this. And I'll show you why. This is what we know about exercise. It improves diabetes control. It makes one's insulin more sensitive. Obesity and a sedentary lifestyle makes one more resistant to insulin. It's great for the entire cardiovascular system. I'm probably not telling you anything you don't know. It helps maintain body weight. You feel better, at least most of us do. It reduces systemic inflammation. Now, this is where the interesting science comes in. And why is this important? Well, when we talk about inflammation, we usually think about type 2 diabetes, at least when we talk to medical students. And I think it is just as important in type 1 diabetes, because the autoimmune attack of type 1 diabetes is an inflammatory process of the beta cells in the pancreas that makes insulin. At least this is part of the mechanism about what happens at the beta cell with the beginning of type 1 diabetes. Furthermore, both the small vessels, when we're talking about the eyes and the kidneys, and the large vessels, when we're talking about the heart and the carotid arteries going to the brain, this is all initiated by an inflammatory process. This has been front page of the Wall Street Journal over the years, Time magazine, Newsweek magazine. Inflammation is a big deal. So if exercise reduces inflammation, could there be any benefits with beta cell preservation, or for that matter, the complications? And the problem is we don't have really good human data. On the other hand, if you're a mouse, I have some good news for you. Because if you're a mouse, there actually are data that exercise increases insulin content and basal insulin secretion in pancreatic islets in type 1 diabetic mice. And this unfortunately is a mouse study. There are other mouse studies. And for what it's worth, and it's not worth much, what I can tell you is that when we see newly diagnosed adults with type 1 diabetes, and they're either on an exercise program or they begin one, I believe, even though I don't have the data to show you, that it preserves longer their ability to make insulin. And I don't feel bad in telling people that because the exercise is good for all these other reasons anyway, even though I don't have any data to prove it in humans. But what if you're not a mouse? I think it's still good to exercise. And we don't know all of this, but there are several research presentations that we have seen over the years at various meetings showing more active children had longer beta cell function. To my knowledge, these abstracts, these posters at scientific meetings, I've never seen written. Maybe there are data written, I just don't know about it. My anecdotal experience is exercise prolongs this honeymoon period, especially in adults, because that's where I have my greatest experience. Now, here's another very interesting case presentation. I started following a 40-year-old man, he may actually be in the room today, in 1991, who was diagnosed with diabetic kidney disease with serum creatinine of 2. That's not good. That means you're at about 50% of your kidney function. That means within the next, depending on what nephrologist you talk to, 3 to 5 years, you are going to need renal replacement therapy, either transplant or dialysis. So I started seeing him back in 1991. He started a pump. His blood sugars had near normal A1Cs, but most importantly, he started a rigorous exercise program. He became a mountain climber. He was riding his bike to work. He did all of these things. And here we are in 2014, 23 years later, his kidney function is no different. Absolutely no different. Can I prove it's the exercise? No, but I see this over and over. So the comment is, oh my God, that's not what's supposed to happen. At least that's not what I was taught was supposed to happen. It's my belief that glucose control, exercise, healthy diet all contributed to his lack of progression of his kidney disease. It's probably not one thing. I think the exercise is very important. And my advice is to start the exercise program early and stay active. Now, but Dr. Hirsch, I already exercise, I eat like a bird, I'm overweight, and no matter how hard I try, my A1C is 8%. Is there a medicine that could help? And by the way, I live in Washington State, so I can't afford my copays. And how many times do I hear this? Patients come in, both men and women, they eat like a bird, they eat like a cardinal, and they come in with BMIs of 34. They don't eat anything. It just sort of happens. Well, we know that's not exactly the case. And so raise your hand if you've heard of the medicine Metformin. Yeah, this is a very, raise your hand if you or anyone in your family takes Metformin with type 1 diabetes. There's a few of you. Okay. Well, that's very interesting. And it's interesting because this drug was actually introduced in Europe and Canada in the 1950s. There is a cousin drug called fenformin. It was in the United States. It was taken off the US market in the late 1970s due to lactic acidosis, which parenthetically had a 50% mortality associated with it. And you wouldn't want to have lactic acidosis and ketoacidosis at the same time. It was introduced in the United States in 1995 with a black box warning, which is the FDA telling us, don't use this in type 1 diabetes, or if you're the doctor prescribing this, we're going to send you to jail. I mean, the black box warning is a very severe warning. Having said that, we've learned quite a bit about metformin over the years. It's safe if used with normal kidney function, and the person who's taking it is not dehydrated. It makes one more sensitive to insulin. And in type 2 diabetes, it lowers A1C by 1 to 1.5%. It reduces insulin requirements. So if you're taking it with insulin, potentially you could have more weight loss. And so in the type 2 studies, mostly without insulin, it's generally weight neutral or a small amount of weight loss. We don't really know how much weight loss we see in type 1 diabetes yet. There's data in type 2 diabetes to suggest it may reduce heart attacks and strokes. That's pretty interesting. Get this, it may reduce the risk of cancer. And there are 20 trials going on around the world right now looking at this as an adjuvant therapy for cancer. so that can't be so bad. And it will reduce testosterone in women with polycystic ovarian syndrome, therefore reducing both hirsutism, the hairiness, and increasing fertility. So one of the side effects of this drug is pregnancy. Not for the men, but for the women. And by the way, it's $4 a month. Pretty cool. But what about this for type 1 diabetes? Well, there are several studies suggest that it works, especially in those who are overweight or obese. My observation is that it gives a modest reduction of insulin dose, a modest reduction of weight and hemoglobin A1C. But I never use this in people with poorly controlled diabetes due to the fear that if that person goes into ketoacidosis while they're on the drug, that is a potentially very dangerous side effect. And patients, we tell them, must come off the drug if they're sick, especially with a viral flu-like syndrome, or certainly if they're having surgery. And what I think we're going to be learning the data about within the next 6 months or so, the big Helmsley-funded T1D exchange, they're actually doing a trial of metformin in overweight and obese teenagers with type 1 diabetes. So we're going to be learning a lot more about the pros and cons of this drug in youth with type 1 diabetes very soon. The main side effects are nausea, vomiting, and diarrhea. About 10% of people can't tolerate this, but clearly it's dose dependent. Some people lose vitamin B12. This was actually on the news last night. There was a vitamin B12 story on King 5, and metformin can cause that to happen. And pregnancy is a side effect in women because of what it does to the testosterone levels. So metformin, introduced in 1995, was the first of many new agents to treat type 2 diabetes. And here's our dirty little secret. I'm going to tell you right now. When new agents are approved in type 2 diabetes, we often try them in type 1. We do. We have these samples. Let's see what happens in type 1 diabetes. So our sandbox of new diabetes drugs has expanded. Our sandbox has become absolutely huge. And so we talk about some of these newer drugs. One that I'm very interested in are these GLP-1 agonists. These are drugs that bind to a receptor called GLP-1. These receptors are in the pancreas, they're in the heart, they're all over the body. And the first one of these agonists is called Byetta. It was introduced in 2010 for type 2 diabetes. And then later we had Victoza, and actually Byetta was introduced earlier than that, so that's a typo on the slide. But Victoza was introduced in 2010, and then a long-acting form of Byetta called Bydureon was introduced in the US in 2012. And the question is, what happens with these drugs with type 1 diabetes? Now, this year, we have two new drugs, one of them that was just released, the other one that's about to be released, Tanzium and Trulicity, introduced this year. So now, if you look at including Byetta and Bydureon as two drugs, we have 1, 2, 3, 4, 5 of these drugs that have hit the market. And a lot of problems with these drugs, nausea, expensive, and we have a real hard time getting them covered for patients here with our system here in Washington State. But in type 2 diabetes, not everybody, but the majority of patients have done extremely well because it both lowers the glucose and lowers the weight. What we've learned is they also tend to work quite well in people with type 1 diabetes, probably because of what they do to the glucagon levels. People with type 1 diabetes often have very high glucagon levels, especially when they eat, and it turns the glucagon off. And that's the main way we think they're working on blood glucose. So if we look for a moment at the human islet, this is just a cartoon, obviously. This is where the insulin comes from the beta cell. And this is absent, obviously, or diminished in type 1 diabetes. This is where the glucagon comes from the alpha cells in the islet. And this is often high in type 1 diabetes and often, and usually after a few years, not responsive to hypoglycemia. And that's the big problem with glucagon. Glucagon is there, but it doesn't increase with hypoglycemia. And it's at the level of the glucagon that the GLP-1 receptors work. Liraglutide is the most studied of these drugs. This goes by the trade name Victoza. And Parish Dandana, who's a researcher in Buffalo, New York, has done the most research on Victoza in type 1 diabetes. And you can see what happens, that the weight went from 212 to 201 pounds after 24 weeks. The body mass index improved. The hemoglobin A1C came down, and the total insulin dose came down. They all came down significantly, not huge, but they all came down significantly. And what's happening with GLP-1s in type 1 diabetes right now? Well, it's a very exciting time for us. So there are these two trials that are run by Novo Nordisk, and I want to thank Novo Nordisk for being one of the prime sponsors of today's conference, but we're involved in the Adjunct 2 trial, which are what's called phase 3 trials to get this drug approved, a registration trial approved for type 1 diabetes. The hope is that with the labeling for type 1 diabetes, insurers all over the country will be able to approve this drug for the use in people with type 1 diabetes. These are called pivotal trials using Victoza in patients with type 1 diabetes with the goal for FDA approval. My guess is we're about 2 years away where we will have another drug labeled appropriately for type 1 diabetes. Our recruitment is over. If you're interested, it was a very short recruitment. It was very easy for us to get our patients. And the same drug, by the way, was recently recommended for approval by the US FDA Advisory Committee for the treatment of obesity. This drug will be out probably next year for the treatment of obesity in a higher dose. We see, not uncommonly, 10, 15-pound weight losses when these agents are used, with, of course, having to reduce the insulin doses that we're using. Raise your hand if you or your child's continuous glucose monitor looks like this. Nobody's raising their hand. So this is a very interesting patient. This was, I saw her in September of 2010. She was diagnosed with her diabetes in February of that year. She was 36 years old at the time. Her doctor started her on metformin. In April, he started her on Victoza. I met her in June. I said, "You're thin, you have blonde hair, have your doctor check your GAD antibody." The GAD antibody was checked. The GAD antibody was very positive. In fact, her child has a positive GAD antibody. I don't think in the TEDdy study. But what's interesting about this young lady who's GAD antibody positive, not overweight, has been on Victoza since April of 2010. To this day, she has never seen even 1 unit of insulin. And I was talking to Matthias last night from the Novo Nordisk labs. My biggest excitement about these GLP-1s is they're doing something very positive to the beta cell. It's an N of 1. It doesn't count. It's anecdotal. But I can tell you that, as of May of this year, her A1C is still 5.6%. Never been on insulin. Kind of cool. Okay, so what's the number one reason people don't start or stop GLP-1 agonists? What's the number one reason? It's because they're very expensive. And that's something I know Aaron Kowalski with the CGM with JDRF. What we need to do with all of these drugs, and certainly even insulin now, is we need to make sure that everybody who can benefit from the better insulins, the better drugs, have access to all of these drugs and technology. The most unique of the new diabetes pills, I think, at least in my opinion, when you look at all the new pills that are being introduced for type 2 diabetes, is the following. Who remembers when the goal of diabetes therapy was to free the urine of glucose? Anybody in the room? Yeah, there are a lot of you in the room. You were around, and some of you are my patients. You were around in those days. Well, those days are long gone. That's the good news. Turns out we now understand most of the glucose, when it gets to the kidney, is reabsorbed into the circulation by a glucose transporter. This glucose transporter is called SGLT2. There's also an SGLT1. If the glucose rises above a threshold, above 180 normally, the SGLT2 is overwhelmed and it spills into the urine. Now, what if you inhibit this SGLT2 transporter so that you actually lose more glucose in the urine instead of at 180, at 110, at 100. So you're always spilling glucose into the urine. What happens? Well, then you have a new drug. Because what normally happens is the glucose gets to the top of the kidney. This is the kidney. SGLT2 normally reabsorbs 90% of the glucose. The SGLT1 is a very small amount of the glucose. But what happens is the glucose comes back into the blood if the glucose is below 180. And what happens is if you actually inhibit the SGLT2 inhibitor, now the glucose is going to come all the way down through the loop in the kidney and come out of the urine. So you're losing glucose, meaning you're also losing calories. So what would you think if you had a drug that inhibited SGLT2? You're losing calories, you lose weight. Remember what I said. People with type 1 diabetes used to always be at a lower weight because A1Cs were all in double digits and they were losing all those calories in the urine. So, do SGLT2 inhibitors work for type 1 diabetes? And I would say they work for any kind of diabetes, whether it's MODY, whether it's prednisone-induced, it doesn't matter. And so this is one of the new SGLT2 inhibitors called dapagliflozin, and it's a very small study. It was just published in type 1 diabetes. And what you can see is that over time, the amount of, the first slide is the glucose in the urine goes up. And then what you see is that the blood glucose goes down over time because you're just losing it in the urine. But what's really interesting is that when we start playing with this, and I use that term loosely, in patients with type 1 diabetes, and these are all type 1 patients here in this slide. If I can go to the next slide, please. If we look at this in type 1 diabetes, this is a patient on the first one, it goes by the trade name Invokana. This is a 62-year-old woman with 10 years of type 1 diabetes. In September, her A1C was 8.1. Her weight was 184 pounds. We started her on Invokana. Now in October of 2014, her A1C is 6.9. Look at all the weight that she's lost from 184 to 157, and that's what her CGM looks like. It's not perfect, but it's a lot better than it was. Because every time she spikes, she's losing more glucose, even if she's below 180. And so there are trials that are starting with this, large trials that are starting with these drugs for type 1 diabetes. There are a bunch of these out. There's Invokana, there's dapagliflozin, there is empagliflozin that was just approved within the last few weeks, and there are many more of these on the way. So to summarize, as a result of our successful use with insulin, those with type 1 diabetes have become obese, like the rest of the US population. Both old and new strategies for type 2 diabetes with different mechanism of action seem to improve both glucose and weight in type 1 diabetes also. As of now, the only treatment approved for type 1 diabetes other than insulin is exercise and Similan. We don't have anything approved, but that's all going to change, I think, within the next 2 or 3 years. Getting Metformin approved by the FDA for type 1 diabetes probably won't happen since it's generic. There's no big pharma company behind it, even though research will likely show it's safe and effective. That's what I expect we're going to see from this teenage study that we'll learn about within the next few months. My guess is that liraglutide or Victoza will be approved for type 1 diabetes within the next couple of years. And my guess is that at least one of the SGLT2 inhibitors will also be approved for type 1 diabetes. So we're going to have all of these new drugs to treat people with type 1 diabetes. What's not a guess is that these add-on agents likely will be unaffordable to most, at least the way things are right now in Washington State, where we're fighting to get people their insulin, although I hope I'm wrong about this guess. I really do. So be nice. Be nice. I'm in charge of the pills. I am. All of these new drugs are nice, but our ultimate goal is not to have you take more medicine, but it's to be free of all of these diabetes drugs with more innovative strategies to be free from diabetes. Nothing less should be acceptable. And this, of course, is my goal. Thank you very much.